So here at ESMO 2019 in Barcelona, we've seen the 5-year overall survival data for Checkmate 067. This was a randomised phase 3 trial of untreated patients who got ipilimumab and nivolumab versus ipilimumab. We've seen the 5-year data, having previously seen the 2, 3 and 4-year data. And what the 5-year data has shown us is that the improvements in outcomes for the ipi-nivo arm aren't being lost year by year. So between the 4-year data and the 5-year data, there's only been a 1% difference. So the 5-year overall survival is 52% for the ipilimumab and nivolumab arm. And what that tells us is that patients who are treated with ipilimumab and nivolumab, those benefits are maintained. We also saw that the average or median overall survival for ipilimumab and nivolumab has not been reached. So that means it is somewhere beyond 60 months. And to think of a time when we would have a median overall survival beyond 60 months for metastatic melanoma would previously been unheard of. So this should be considered a new standard of care when we're able to access it for patients with metastatic melanoma. So looking at the data presented here at ESMO, there's some subgroup analysis that we should look at, and that's particularly the BRAF wild type versus the BRAF mutant population. So in the BRAF wild type, they didn't seem to benefit from the nivolumab and ipilimumab as much as the patients who were BRAF mutation positive. The BRAF mutation positive patients did the best with ipilimumab and nivolumab, and what that tells us is that these patients should be having ipilimumab and nivolumab as their first-line therapy. Unfortunately, in Australia, that is actually not possible according to our reimbursement guidelines, but there's no getting around that this is what the data says should be standard of care for our patients. The latest data presented here at ESMO shows us that there was no difference in the quality of life between the nivolumab and ipilimumab arm and the nivolumab arm. So what that means is that even though there is more toxicity associated with combination therapy, it's not significantly impacting on our patients' quality of life. And we shouldn't use that as a reason not to use combination therapy when it is otherwise indicated for our patients. So in routine practice, nivolumab alone is exceptionally easy to give. So for the majority of people, nivolumab is associated with some fatigue, some arthralgias. We do get some hypothyroidism between sort of 8 and 15%, but that's relatively easily managed. There's the 1% incidence of pneumonitis, hepatitis, colitis and nephritis, and again, relatively easily managed. So nivolumab for the majority of people is pretty easy. Everybody knows that ipi-nivo is harder. So ipi-nivo has more side effects. We have a much higher incidence of colitis, a higher incidence of hepatitis. The endocrinopathies, except the thyroid one, which is the same, are higher. So it's tougher, but it is manageable, particularly if you if you've never done it before, you've got colleagues that you can reach out to if you run into strife, or if you're doing it, or someone like myself who does it all the time, if I run into problems that I've never seen before, I reach out to my colleagues or involve other specialties. I don't think the toxicities of ipilimumab and nivolumab should deter us from using it, particularly when we see the median overall survival and the 5-year survival that we have seen today. What we need to be thinking about if we're uncomfortable with using ipi-nivo is, what do I need to make myself comfortable? Which colleagues can I talk to? What other specialties can I get involved? At the end of the day, there will always be some patients for whom combination therapy is inappropriate, and those are patients who are either not well enough from their comorbidities, or their comorbidities are such that it would not be appropriate, such as a severe underlying autoimmune condition, and that always needs to be taken into account. In day-to-day practice, nivolumab and ipilimumab is very manageable, particularly with the help of our colleagues and our other subspecialties. So here at ESMO today, we saw some data looking at subsequent therapy and time to subsequent therapy in the different arms. With the nivolumab and ipilimumab arm, the time to subsequent therapy was much, much longer. And so what that is telling us is that when our patients are having nivolumab and ipilimumab, they are getting a higher response rate. the duration of control is longer, and the need for any other additional therapies is much, much less. And so they are not requiring additional surgery, additional radiation, additional other systemic therapy agents. It's telling us that it is a truly effective therapy by way of not needing any additional therapies once you have completed it. Checkmate 067, the data presented here in Barcelona today has been excellent data. So it shows unprecedented 5-year survival. It shows median overall survivals we would never have dreamed of. But we have to take that back to Australia. And we have some problems in Australia with our regulatory and reimbursement processes. And one of those is about the wording for use of nivolumab and ipilimumab. In that for our patients with BRAF mutant melanoma, which is 40 to 45% of the population, the current reimbursement says they must have targeted therapy first. All the data shows that if you have immune therapy after targeted therapy, it is not as effective. And so what that means is this excellent data that we see here doesn't apply to half of the population. And what it shows us is that excellent data that we saw in Checkmate 067 for the BRAF mutant patients who got the most benefit isn't applying to our patients. And so we as Australian medical oncologists need to continue to work to advocate to change the reimbursement restrictions for nivolumab and ipilimumab for our BRAF mutated patients so that they too can have the possibility of a median overall survival that exceeds 60 months.